All right, and that'll get us started. So good afternoon, everyone, and thank you for joining us at the third session of the Be Well Texas Systems and Sustainability Echo. My name is Andrea Roche. I'll be facilitating our conversation today. I just have a few housekeeping notes before we get started, so bear with. As you just saw, we are recording these sessions for later distribution through the Be Well Texas YouTube channel. So any information you put in the chat will not be shared in those recordings, but you may choose to rename yourself if you want in your Zoom screen just by selecting the three dots on the upper right square where you see your face or your name right now. Please do stay muted unless you are speaking, and we do encourage everyone to speak, but we do ask that you keep your comments brief just to allow space for others to speak up as well. If you join by a computer, that mute button is at the bottom left of your Zoom screen. If you're on the phone, which I don't think anyone is, just press *6. We encourage everyone to join by video, especially for the case presentation and discussion portion of the session, so the latter half of the session. But we're happy you're here, regardless of how you're here. And don't forget, you can also use the chat to share questions, share your experience, or raise comments throughout the session. But do note, whether you're speaking up or you're sharing information in the chat, no protected health information is allowed in either space during this session. To help us with attendance, please enter your name, your affiliation, and your email into the chat function. If you join by phone only, just know that you won't be able to access that function. So we do ask that you email the Be Well Texas team. We'll put that email in the chat here. And I just want to reiterate to all the Be Well Texas providers, make sure you identify yourself during this session. And remember, if you're joining by phone and you can't communicate that to us, email us your name and your number so we can make sure you've recorded your attendance today. Towards the end of this session, the Be Well Texas team is going to send out a link to a post-session evaluation survey. We want you to fill it out for a few reasons. First, it gives us valuable feedback on how we can shape these sessions to better fit your priorities, but also anybody who enters this is entered into a drawing to win a $30 Walmart gift card. So please do give us that feedback. Today's didactic will discuss challenges and strategies for enhancing workforce engagement. Following that, we'll hear some announcements from the Be Well Texas program and then a case presented by Jennifer with Superior Health Plan. So we're going to get started with some introductions of our team, followed by those didactics and announcements in our case presentation, an open discussion that I encourage you all to join in. This space is what we make of it. So I really do encourage all of us to think of ourselves as teachers, think of ourselves as learners, and to share our experiences, our questions, and our insight into today's conversation. So let's introduce the team. I'll start with you, Matt.
Hello, folks. Good to be with you. I'm Matt Roosa. Background is in NITEX model, process improvement, quality improvement. I've spent time as a clinician in behavioral health, also as an agency administrator and in government planning. Now work full-time as a consultant. Happy to be with you.
Thank you. B.
Hello and welcome, everyone. My name is B, or Briseida Courtois, and I'm part of the team with Be Well Texas here at UT Health San Antonio, and I am one of the program managers. Again, thank you for joining us.
Thank you, B. Kathy.
Good afternoon, everyone. I am Kathy Hudgins. I'm the former executive director of the Center of Excellence for Integrated Care. I have spent pretty much the last couple decades working in behavioral health as a professor at one point. And I'm also a faculty associate for Arizona State University, helped develop the Master's in Integrated Healthcare Management, and currently work as a consultant and also a hub leader for another ECHO. So hello.
Thanks, Kathy, for joining us. Andrea.
My name is Andrea Hamler, and I'm a project coordinator for CSTAT and for ECHO. I'm here at UT San Antonio. Happy to be here.
Thank you. Jennifer.
Would that be me?
Sorry.
Fantastic. Jennifer's, there's usually a lot of us. I'm Jennifer Berkman. I'm a manager for Superior Health Plan, and I work with the Medical Management Complex Case Management Department.
Great. Thank you so much for joining us today. And Adrian.
Hi, everyone. Thanks for being here. Adrienne Lindsay, I direct our Center for Substance Use Training and Telementoring. My background's in integrated behavioral health care and implementing evidence-based practices.
Thank you. And thanks to all of you for showing up. Just a reminder, because I've seen a lot of folks join since I first said it. To help us with attendance, please do enter your name, email, and chat into the chat function. Carly will send out a reminder of that. We're going to get started with our didactics. Matt, when you're ready, take it away.
All right, thanks, Andrea, I appreciate that. As was announced previously, we're going to talk a little bit about issues related to workforce engagement. So this will hopefully prime the pump nicely for our conversation and our case example. So, and I want to talk with you about some workforce issues for a few minutes across this continuum of recruiting, hiring, retaining, and promoting individuals within your systems. So a lot of my thinking related to workforce comes from the experiences working with supervisors and managers in different healthcare environments who are, as you well know, incredibly stressed and challenged in large part as a result of workforce challenges, retaining. We have all had this experience of talking with supervisors who are pulling double shifts just to cover their program residential environments where they don't have overnight staff. So the supervisor's there overnight because they can't maintain the employment levels that they need to in order to have a healthy functioning team. And the painful thing that occurs is folks get terribly burnt out, stressed, challenged, and they often leave and they go work for Best Buy. In behavioral healthcare, often they go work for Best Buy because they make almost as much or as much money and their life is a lot easier and their schedule is much enhanced. Obviously, there are a lot of big systems drivers that relate to this challenge. We're going to talk about a few of the things that organizations can do internally. Last month at our ECHO session last month, we talked about this cycle. If you start at the top right, there's this demand and challenge in terms of volume and acuity, more folks in need of care, higher levels of acuity. And then in conjunction, thinking about this cycle of reduced teaming, and by teaming, team as a verb, right? Teaming and engagement, pressure on the system, which decreases the amount of interactivity, healthy interactivity related to teamwork, constraints around telehealth, remote work, et cetera. And then we have resulting staff burnout and then loss of staff or reduced productivity of staff. All of these things contributing to burdens and challenges of staff teams. And then thinking about that across this staircase process of recruiting people, retaining people, hiring people, retaining them, and promoting them. I think one of the most challenging elements of this process is that the more you need it, the harder it is to do as it relates to workforce engagement. Why do I have this big fat pill on the screen? It's sort of a metaphor. Imagine if you had a medicine that you needed to take, and the sicker you got, the bigger the pill got. So it's harder and harder to take the pill because it keeps getting bigger and as you get sicker. So if you're not on it very proactively on the front end, when you're just starting to become symptomatic, where you can manage the medicine, it starts to get harder and harder. And I think that's one of the things that happens with staffing. We don't have this instant urgency. We have this urgency across time, which then tends to reduce our agency because it gets harder and harder to actually respond and do something to help our teams. And so we see these downward spirals. Now, I don't want to get too cynical or negative about this process because it's hard for many of us. So let's talk a little bit about some of the things that folks can do. For a minute, let's work our way through those stair steps, those 4 areas. First, thinking a bit about recruitment. Some of the challenges around recruitment: diversity, equity, and inclusion, making sure that we have a diverse staff that represents the communities we're serving. Enough people, are we able to pay them enough? Do we have certain shortages related to certain types of credentials, et cetera? And so what are the strategies that we can use in recruiting? Probably some of you are doing creative things. Where are you recruiting? Who can assist you with recruiting? How do you enhance your descriptions? Some of us have done interesting experiments as it relates to recruitment, where you do one job description and you get 7 people who apply, and then you change the job description and you get 27 people who apply. I mean, that's a nice quick process improvement strategy to try to work on your messaging. Some folks don't spend enough time on the languaging and messaging as it relates to those recruitment efforts. And trying to go where people are, where people go when you're trying to recruit. There's a lot of talk around barbershops as good examples, either for delivering of certain kinds of prevention or care opportunities, and or as hubs in a neighborhood. You know, what are the hubs? What are the hubs in terms of the demographic population groups that you're trying, who are you trying to engage in your service? And to try to find those places and partner with those natural places of connectivity within the community. Now, the same old advertisement and the same old periodical or same old Indeed list is not necessarily going to give you what you need as you're trying to recruit folks. So then thinking about hiring, those challenges around salary and those similar shortage issues, competition between providers, and what can you do to market your culture, create a sense of meaningful culture for folks to come and stay with you, what it is about you that's unique and different. Are there things that you can use for strategies to market yourself effectively? I like to think about the psychological safety orientation. Do we show folks when we're trying to hire them that we have a culture that's nurturing? The phrase at the bottom, know, grow, and show your culture's values. It starts with know, because if I ask organizations, what are your cultural values that you try to communicate to those who you are seeking to hire? Oftentimes I don't get a response because people don't maybe orient themselves in that direction when they're trying to recruit. They talk about the job and the fulfilling nature of the job, but they don't market and promote the culture within the organization and how it can be meaningful and purposeful and nurturing of the individuals who are being hired. So how do we create that opportunity for people to see the organization's culture and its values and how that can create opportunities for them if they are employed there? And then thinking about retaining people. How do we, again, work out through some of these challenges? How do we create ladders of opportunity for retention, create new experiences, and maybe even flip the whole structure of it to say, you know, we're going to just embrace turnover. We know that we're going to turn over a lot, and as such, we need to kind of create different structures and just acknowledge that reality and build certain structures around that. So thinking about these costs of turnover through the sequence and how people quit positions. You know, we have these hiring challenges and shortages, and stress on teams and burnout. So what are the things that we can do to retain folks? What are those retention maximizers that can reduce that stress, reduce that burnout, get people to stay, reduce that hiring challenge and that shortage? So where do we think about those elements that are the retention maximizers around stress and burnout with our teams? And not to call folks poultry, but a silly, simple metaphor, fence or feed. Do we fence people in and say, don't leave because, and try to hold on to them? Or do we try to encourage them, nurture them, feed them, and say, stay because, right? What's our culture around how we think about retention? You know, do we really invite people to be a part of who we are? And then that promotional idea, I think ladders are important here as we think about promotion. Many organizations are pretty flat and they don't have ladder opportunities for folks to be promoted. Sometimes we need to be really creative in coming up with unique opportunities and experiences for folks to be able to give them a bump up. Maybe it's not always a bump up in salary. It could be a bump up in different kinds of opportunity or experience or responsibilities that are manageable and meaningful for them. How do we get creative about doing that, even in a smaller, flatter organization that may not have a lot of tiers of promotional opportunity for them? So thinking about this journey that people can take with us, I think sometimes folks don't do this because it feels a little corny and they maybe aren't comfortable talking about it that way, but these things really mean something to our new hires and to the folks as we're trying to retain them. How do we say we're on a journey with you and we want to you to stay with us and work with us and be part of who we are and part of this journey with us? So with that, I will wrap up, and hopefully that gives us a little bit of at least in terms of the lens around staffing and thinking about how you can recruit and retain those staff members who are meaningful and helpful to your culture, to your organization and its mission.
Terrific, Matt. Thank you so much. Great presentation, and I think a kind of critical one to visit in this time of burnout and volatility in the job market. Opening it up to the learning community. Any questions for Matt for this presentation?
Matt, I have a question for you. My name is William Thomas. I'm a stud supervisor for Emergence Health Network. So I run about 5 programs. And the first thing that caught me is that you said a lot of people were going to Best Buy because of the price people pay at Best Buy. And I really touch base with that because I've been offered other opportunities that are not in. Let me turn my video on. I don't know if my home network will show it, but
There we go.
so good. Here I am. So I'm asking that question, and you know, the begging question is, I hold 2 masters, a dual masters in mental health and a dual masters in drug addiction. But nowadays, like you said, with that finite line of the pay, what do you suggest that we would do to our higher ups, or any options to our higher ups, just to suggest maybe a payment increase? I mean, I believe everybody on this call understands that the behavioral health field, especially in the opiate health field, is very stressful. So I would love a punch in, punch out job, but unfortunately this job is 24 hours a day and it's tough and it does wear us thin. And as for myself, I do run 5 programs, not all opiate based, but what would you recommend? How could we get this spread out to the higher ups?
Yeah, this is a great question, William, and I think it's the bigger, broader economic drivers. We pay for what we value, and if we as our system continues to try to move itself toward payment for performance, toward preventive kinds of care, toward appreciating how working with folks at lower levels of care can save huge amounts of money and can increase health, all these things that we know, and our system continues to struggle to make those shifts. And if we value and understand those things, then we start to value and appreciate behavioral health care as a hugely successful means of preventing more intensive care, preventing hospitalizations, et cetera. And so then we start to generate more revenue toward behavioral health care and higher levels and rates of pay. I think administrators get the finger pointed at them. Why can't you pay our folks more money so they don't go to Best Buy? Unfortunately, the response back is typically because we don't get paid enough to pay them more. And so this bigger, broader systemic dynamic is, I think, where many of us are looking to see if we can really move toward that pay for performance and understand the value-based payment model around behavioral health care as tremendously preventive and cost savings.
So what I'm understanding is like basically this is something higher than just the company that I work for. This is something that's going to come from the government and how much money they're going to issue out to what we do for a living. Because I think
it's a both and for sure. There are things that your system can do to try to find ways to pay more, to value, to retain folks, and find other things above and beyond payment, but also, yes, that broader economic driver of the system in terms of what we value. Our system tends to be so more reactive than proactive, more responsive to crisis care needs than preventive care needs. And how do we keep trying to help it to resort that so that we value your services and how they are critical and preventive.
Okay, I agree. I agree with you 100%. Thank you very much for that
Sure.
answer, because I know I love what I do, but I just can't see myself being a checker at Best Buy. So, I mean, it's one of those things, but I mean, money drives the world. So a great presentation. Thank you very much, Mr. Rosa.
Can I say something to William just really quickly?
Of course, sure.
As they're hiring more people, they are also vying for the same people who are being, lured in by Best Buy. So I wonder, going to HR and looking at a market analysis and doing some kind of comparison, are they having to offer people who are coming into your organization a higher rate to get them to come in? And if so, or will they re-level their current workforce to reach that and bring it up to where they are putting their new hires? I know organizations, they're having to do that because some states are actually changing, minimum wage, and they have to do that for the entire workforce, but they're also doing it because of the staff shortages and the competition for the workforce.
And I agree with you. Thank you for that. And I actually have done that. I've gone to the HR and asked questions, and we got a 2% raise this year. So, the people that are out there in math, I mean, 2% with the price of gas right now. I mean, that doesn't even cover the price of gas getting to the office. But then again, also, I'm in West Texas. I'm in El Paso. So I'm as far as west as you can get. And there is a very minimal supply of LCDCs or LCDCIs. So when it does come down time for them to look at a job description and the qualifications, they automatically mark themselves out because they don't have that. With little to be known, I mean, $65 and an associate's degree, you can be an LCDCI. So, it was just a curious question. I'm not planning on leaving the field or doing anything like that, but I mean, money drives the world. And sometimes it's difficult because I see my wife working from home, making, $22 an hour, and she's able to punch in and punch out. And God, I wish this field was that easy.
Yeah, I think, well, thank you for sharing the personal detail, and those were really great questions. I don't want to miss the question from Alfredo here in the chat, posing this to our speaker, Matt. You think distributing an employee satisfaction survey and sharing the results with the staff would be beneficial?
Yeah, I am a big fan of surveys, as I say, with the caveat, as long as they are a survey that creates dialogue and interaction. Sometimes our surveys are unidirectional, where we say, give us all your information, and then we don't talk to folks about what they've told us. As long as it creates a loop and you complete the loop and you dialogue with folks about the results, and it becomes an opportunity for conversation with your team. And that's how you build culture and build team and work effectively with each other. And that's how you learn what people value and what they need and what they want. And that's where you get to that individual level. We know some, general, more broader global things that we can do to enhance the work experience. And it's really helpful to inform that by individual responses. And that's where you get down to person-centered orientation, more culturally humble, culturally competent in terms of what individuals are describing to you as their needs, what helps them to feel good about coming to work every day. So yes, I would strongly encourage that process.
Terrific response. Yeah, survey in a vacuum won't do much, but as part of a larger strategy can be valuable. Thanks for the question, Alfredo. Well, if you have other questions, feel free to pop them over in the chat, and Matt can either respond to them or the group can. But let's jump over to some updates and announcements from the Be Well Texas program. Carly, if you wouldn't mind sharing the slides. So a little bit more about Be Well Texas. This is a welcoming environment with caring professionals ready to help people start or continue their journey toward recovery. Be Well Texas is committed to expanding equitable access to compassionate, evidence-based treatment and care for substance use disorder throughout Texas. Next slide. The Be Well Texas Clinic offers low-cost, self-pay, and no-cost services for patients affected by substance use disorder, and they also have insurance options available. Next slide. Want to let you know about 2 new programs coming through Be Well Texas. The first is the Public Safety Echo for public safety professionals and first responders, and then also the Substance Use Disorder Echo targeted to behavioral health specialists. Next slide. I do want you to remember that we're continuing to offer the other series as well, including TexRx, Recovery Support Services, and the Shout Echo, and a harm reduction series. Not listed here, but you can certainly find it on the Be Well Texas website. And again, remember, you can register for any of these series through bewelltexas.org. Next slide. And we hope to see you again next month at our Systems and Sustainability series to discuss stigma in substance use disorder. All right, I think that ends the slides. Great. At this point, we're going to get into the case presentation for today. So Carly will share the case. And Jennifer, when you see that, can you tell us a little bit more about the situation you've brought to us and what you're hoping to accomplish with today's session? Thank you.
Absolutely. So the thing that I was asked to speak about was how our health plan has addressed the barriers that's been created by the opioid crisis. And so as you can see, we actually have a whole bunch of different professions that work for Superior Health Plan and collaborate together. We're gifted to have physicians, pharmacists, RNs, LPCs, social workers, and community health workers. And so we really do get to pool the best of each of those areas together to address the needs of our members the best that we can. So again, when we look at A, your contribution to community need, we work with members and providers to address physical, behavioral, and cultural issues as they relate to healthcare and work to find solutions for better outcomes. And it isn't just physical health or behavioral health. We do a lot of social determinants of health support and just whatever kind of areas that the member needs, whether it means pulling in a family member as a support or a caregiver and providing education. So we try to tackle the issues, all of them, from a whole bunch of different angles. So our desired outcome, and I think this is true of just the field in general, is to provide the best care possible for members. You know, we are honored to serve some of the most vulnerable citizens in our communities that have such high and complicated needs. So that's our desired service outcome. And then our funding structure, as an MCO, we receive funding from the government and other entities. We have partnerships. And so a lot of the pay discussion is about 2 pay grades above mine, but that's a brief overview of that. And so basically our challenge is getting our members to be able to access timely and affordable treatments to treat the opioid use disorders. And a lot of times what this looks like is, you know, access is an issue. There's obviously not enough resources out there. There's starting to be more and more, and that's a great thing. But there just isn't enough yet. We're building towards it. Affordability is also another issue that we run into, because a lot of times treatment isn't affordable to get into. People either don't have insurance or they do have insurance and the insurances don't quite cover all of the services. And then another challenge would be attitude. You know, a lot of times with our members and their family, addiction is still seen as a character flaw and not as a disease. And so a lot of this is the education piece of the members and the providers and family members. And then also another one of the challenges is addressing pain management needs. We have a lot of people, let's say our members with sickle cell, you know, they have a lot of pain associated with that, and it's a chronic thing. And as we know, that chronic pain management is a big piece of the opioid crisis. So when we talk about the strengths, we have 3 pretty good strengths going for us. We approach healthcare in a collaborative way, again, leveraging the different strengths and gifts of the providers, our professionals, internal and external partners, members, and, you know, again, community partners' knowledge and experience. It's very much a relationship. who's out there in the community that are seeing these members, who are doing it well, and which ones maybe not doing it so well that we can come in and partner with and educate them. And it's also really helpful that we have case managers that are more clinical. So you have your LPCs and your nurses, and they partner with our service coordinators, people that can come, pardon me, and assess for, does this member need home health services? Do they need home delivered meals? And so we can help hook them up with those type of services and supports. And then we have our community health workers. These are staff that are trained in the communities that they live in. What resources are available? What partnerships can they help link these members to? So we really do try to address a 360-degree view of the member. And then another key strength is that we strive for innovative ways to establish new approaches and enhance existing approaches that are working. So whether it be an alternative payment model or a new partner that's in the community, we're always looking for new and better ways to do what we do. We try to stay up on the latest research, and we look for different successful strategies. And the neat thing about Superior is we're obviously under a bigger umbrella of the national corporation, which is Centene. And so we have all these different health plans across the US. And if California's got something really brilliant going on, then, what are they doing and how can we borrow and what can we learn? And so we have that conversation going. And then the last one is one of the biggest advantages, I think, is our pop health data. We're able to get information about our members from pharmacies, from PCPs, from hospitals, from ERs, and just bringing all of that information together to get a better picture of the opioid crisis. Again, what areas is it impacting more? Which areas in Texas have the most social determinants of health needs? And that influences things. So that, I think, is a huge advantage that we have. So then moving on to what past successful implementation strategies have we used that can be applied? And we're actually doing a whole lot of different things. And I've mentioned some as we've been going. But one of the things we do is provide our oversight. And so when our case managers and service coordinators are meeting with our members, we're looking at what kind of meds are they being prescribed? Are they being overprescribed? Or is there something lacking? Or is there evidence that this provider isn't talking to this other one and they're both prescribing contradicting medications for this member? And so we have the ability to contact those providers and provide some education. Hey, did you realize this person has a different provider over here that's prescribing this set of medications? Another tool that we have is something called pharmacy lock-in. So if we have a member who might be seeing multiple providers and maybe getting prescription filled at multiple pharmacies, again, that leaves the member open to a lot of really negative things. And so we're able to say, okay, we're going to put you in a lock-in pharmacy, which is one pharmacy that you need to get all of your medications filled through. And that just gives us a better oversight of what's going on. And on top of that, we do provide that member with education. It isn't just, okay, you're stuck in this lock-in pharmacy and that's it. It's constantly trying to say, hey, you're having this issue and you're having this pain management concern. Well, how are you addressing it? And here's some different ways you can do that. Providing provider education. Maybe it's teaching them about medication-assisted treatment or some other things that we're finding helpful trends. And then also looking at different concerns of the member. Again, that 360-degree view. Is the opioid use maybe not a physical health concern? Maybe it's a behavioral health concern. Maybe it's some untreated depression or bipolar disorder, or perhaps maybe it's from past trauma, and that's really influencing how the member's treating different things. We also, again, do look at social determinants of health, even up to and including housing support. So we're really starting to figure out that piece that if a member has solid housing, they're going to be a lot less at risk for some of these things than a member that might be facing homelessness on top of their physical challenges, pain management, and then dependence on opiates. We are constantly training our staff. We train them using motivational interviewing techniques, so that way they know how to elicit that change talk from the members. And we encourage evidence-based medication-assisted treatment with our providers, and just educate the case managers so they also have that background. And looking towards a harm reduction model, we're, as a society, getting away from just relying on the 12-step method and the abstinence method of treating substance use issues, and looking at that harm reduction model and how that can fit in there as well. And then increasing peer support. We have a lot of peer providers and things like the San Antonio Clubhouse and the Austin Clubhouse. And those are great supports for members that have behavioral health and substance use disorder issues. So, all right. And then what were the best indicators that you had successfully resolved this current challenge? What does that look like? And when we start seeing a decrease in member mortality and negative health outcomes linked to the opioid use, then we'll know that we're on the right track. And also an increase in treatment options and availability. So that way, when they do get to that point in their journey where they're like, I want help, they can access that in a timely way and effective way. And so I guess my question to you guys is, what are you guys doing to address this issue? What have you found that is working or not working? And that's it.
Jennifer, thank you so much. That was a really terrific bird's eye view of system level considerations for addressing substance use disorder, and appreciate you sharing sort of multiple dimensions of that work, whether on the clinic level or the patient level or the community level. You did my job for me and asked the question to the learning community, and I'll repeat it there. We want to hear what other people are doing, and also other questions you might have for Jennifer and the case she presented.
I'll jump in. It's William again from Emergency Health Network. Jennifer, I would like to ask you a question. When somebody gets referred to your office-based opioid treatment program or the MAT therapy, what is the time frame for them to have to wait? If that doesn't make sense, I'll explain mine, and then you can relate to that.
So I think it varies depending on the program. We have a lot of different ones that contract with us, and it's, obviously based on their availability and also member need. If we have a member that has a lot of complex needs, a lot of times it's gonna take a little bit longer to fit them into a program.
Okay.
But we try to do it as fast as possible, because when that motivation strikes that person, we want to get them in, get them hooked up, and get them going.
Got to do it. So then let me ask you a question. So right now, the way that we have set up for getting people into our OBOT program is they do their lab work on a Friday. And then we only have inductions twice a month, which to me, being the supervisor, is kind of like, man, I wish I could pay the doctor more to be able to be there, to be able to induce them. And then there's also, the contractual requirements of the follow-up, and then the 2-week follow-up that we do have to follow. So what I found is that we're running into a lot of problems with these individuals being able to make either their initial appointment, or they'll go do the labs and won't make the induction appointment. Then they don't come for the follow-up appointment. Or if they do come for the follow-up, they won't come for the 2-week follow-up appointment. So I'm running into barriers along the way. And do you have any suggestions on how I can shorten the time frame? Because what I would like to do, instead of inductions 2 weeks out of the month, I would like to have inductions, in a perfect world, 5 days a week, right? But and in this world that we're living in right now, maybe, shoot for 2 days a week instead of bi-weekly. Do you have any suggestions on how that could be done?
Well, one piece is, you mentioned, the member actually getting there. And I know that for our superior members, We have a transportation value add service for them that they can get to those appointments. And so we're trying to remove as many of those barriers as possible. And, you know, again, the more knowledgeable we are about the different programs that are out there and the availability, the better we can help. And if it's a member that can't get into, let's say, Synacor, and I'm just pulling it out of my head, well, are we looking at PHP, partial hospitalization programs, or intensive outpatient programs? And really, what is the menu of options, and trying to tailor that? If they can't get in door A, where's door B? So I don't know if that exactly answers your question, but
No, it does, and it gives me ideas, because you brought up the fact of transportation. And like I said, I'm in West Texas. We're a border city. We suffer with a lot of homelessness. So transportation is really a key factor of being able to get them to fill these contractual requirements. So that put an idea in my mind to reach out to some friends that work at different agencies like Project Amistad or Project Bravo, which are agencies we have here that might be able to provide the transportation. As a matter of fact, it got me on it to where I'm going to text them right now and see if we can have a conversation this afternoon about it.
that's fantastic. And you bring up another really good point. This is not news to any of you guys, but Texas is a big state. And it's really interesting to have the vantage point of the different communities in Texas, because the needs out in West Texas and the culture out in West Texas are going to be very different than the culture in Austin or in Dallas. So it's really keeping in mind too, where is that member and what is their culture and what are their needs around that and what are the supports around that? Because I know for my Hidalgo people, family is everything down there. And if you're going to have the member engaged in treatment, you also need to be considering how the family piece fits in that as well.
And that's I agree with you completely. That's the way that it is here. 95% Hispanic culture, but unfortunately with that culture comes unemployment, comes lack of transportation, lack of vehicles. So picking up on other community resources, I think is going to try to be the key. But at the same time, even if I can get them the transportation, like you mentioned in your didactic, is that when they're ready to go, they're ready to go. But I'm the one who has to sit there and tell them, okay, you're ready to go, but you need to come in this Friday for labs and not see the doctor until 2 weeks from now. Right. And, is other than paying the doctor more, then we go back to Mr. Rosa's thing of where's the money coming from, because these doctors don't want to really do it for free. And I've also reached out to our local community hospitals and trying to gain a relationship with our hospitals, because we have a lot of people who go in and can't find the opiates. And that is their turning point. They say, you know what, I'm going to go to the hospital, I'm going to detox. But then the hospitals will only allow them a 7-day supply, maybe of Subutex or Suboxone. And we can't fit that 7-day supply within our 2-week time frame. So we leave them 7 days wondering, are they going to be able to hold on by themselves? Yeah. And that's being not good. An addict in recovery, that's not good.
Sorry, Kathy, I interrupted you. Go ahead.
I have a question, sort of going back to Jennifer's sort of framework. Do you all help develop those partnerships to address these kinds of barriers, including things like finding maybe an FQHC that person could actually get a prescriber through, and then make those links for organizations like William, and then come up with ways to engage the patient? You said you have peers too, so to hold their hand through this process as they go through that. And do you all also pay for home induction? There's a question for that. I know that in other states they do pay for home induction, but anyway, I was just wondering on the MCO side, this could be, are your policies even more flexible also because of the region? Are they regionally different? Is there any flexibility? So that was just my question about your sort of challenges in getting these providers?
Gotcha. So, I mean, obviously our policies are kind of our framework, but we're also allowed a lot of that innovation piece and the creativity, because the better we can solve the problem, you know, the better it's going to be overall for us, for the member, for the provider, for everybody. Now, the home induction you were talking about, I'm not familiar with that. Could you explain just a little bit?
That's a big conversation, so we'll drop that.
Okay.
But we do in several states do allow the initial home induction based on an assessment criteria.
Okay.
So I want, yeah, that's somewhere else.
Okay.
But I
no
just
worries.
wondered about some of the flexibilities for the rural areas that would not be needed in your more urban. Does your MCO have some of those sort of accommodations?
Yes, and we're starting to look more and more about how to better serve our rural members, because they obviously have different needs. There's just less availability to everything. We are pushing a lot of telehealth too. We found that that's a decent workaround. It's not spot on yet, but as we go, we're increasing that more and more. And so we have the ability for our members to access psychiatrists from around the state. If somebody has an opening in Lubbock and I got a member in Corpus that needs to get in and see a prescriber for psychiatric stuff, we have that. We have telehealth counseling that we can refer members to, and then also MD services. So we're looking at the rural health and considering those. And the FQHCs, we definitely partner with them. We're always out doing educational things, and just to not only bring the message and the education to the members, but also increase those partnerships and those relationships, because those guys are boots on the ground. You know, they see what's going on, and we need that knowledge and that partnership.
And I would like to add on that note related to telehealth. We do have more and more providers here in Texas that are offering the OBOT via telehealth, which is very convenient to address the issue of the opioid crisis, especially in rural areas because of the transportation issue. It could be done via telehealth, and a lot of these providers are supported and funded through HHSC or through state funding. So that is another great resource for individuals that live in very rural, isolated areas and have that OUD or opioid use disorder diagnosis. They can get started on buprenorphine via telehealth, get their medications mailed. Everything takes place via telehealth, and that has really helped in addressing this issue for that specific population that is very isolated.
Yep. And we're also able to tailor the level of support to member needs. We have some of our members that don't need too much, and contact with them is much less frequent than those members that are going in and out of the ERs and going in and out of inpatient that need just that increased level of support. And so we're able to tailor our support to that.
Well, thank you both for the great discussion. The question I have, and it's for the larger community here, and bear with me, I'm sort of figuring out how to ask this, but I got to this question from what William asked earlier about wait times. And it made me think about the data that is being gathered and whose perspective are we seeing with that data, and whose goals are we acting upon? And so my question to the larger group is, does anybody have experience with or strategies for understanding the different goals of the different stakeholders in this system? So stakeholders could be an MCO, could be providers, could be the clinic, could be the patient, could be the wider community, but strategies for understanding the different goals of those different communities and finding agreement between some that might be conflicting, or acting on those different goals in measurable ways, not just sort of aspirational ways, but measurable ways. It's a very large abstract question, so sort of take it as you might, but I'm interested in that because we see that the goals of these different stakeholders are all very important in this conversation.
Andrea, I can speak to one model that I've used in rural areas. It comes out of the National Institutes of Health. It was through the criminal justice drug abuse treatment studies. And the model's called a change team. And it's not too dissimilar there's a lot of other similar models essentially, but you get all those stakeholders at the table, as you mentioned, payers, providers, if you look at patients in the room, that's also fabulous. Folks from other sectors like criminal justice sector, and you get everyone in the same room if you can, bi-weekly or monthly, at least monthly, and kind of sort out all those challenges in a given region. And it can be really helpful because a lot of times those different parties aren't talking to each other that directly, or there's conversations happening, but they're kind of segmented. And so to have everyone physically in the same room, and the model's kind of involved, I can share it with folks offline if you're interested, but they essentially go through sort of a strategic planning like process together for their given region and address all kinds of issues like this, whether it's wait times, transportation, just better team-based care and communication across different sectors. And even just that act of getting everyone in the same room on a semi-regular basis can be really helpful. It's kind of a change coalition of sorts is how you might think of it. But anyways, if anyone's interested in that, and actually Matt is probably intimately familiar with it through his Niatex work, but it's a useful model.
Absolutely, Adrian. And the power of what you just described, that broader change team, as it relates to one of Andrea's points around wait times. Sometimes the different constituencies have different values around things like wait times. Some parties might say, well, it's easier for us if the process is slower. Now, that might not be the customer service orientation we might aspire to, but the team can work together and can say, you know what, maybe it's not easier if it's slower, because when it's slower, people will drop out. They'll require additional resources in terms of reconnection and engagement, and they'll be struggling more. And so when you do engage them, there'll be higher needs, higher costs in staffing and other services. So maybe a more efficient flow on the front end is good for everybody. So those are the things that emerge out of that dialogue, that customer service. It's sort of the good for all parties in terms of excellent customer service and rapid engagement in care.
Another thing that a group of MCOs did in North Carolina, when they were trying to sort of parse out the 100 counties there were so very different, they assigned a liaison between the MCO and their provider groups and their community groups. And that person, their sole job was to actually survey and then have these focus groups, but also bring back those challenges and then put them up against the way that the service lines were being reimbursed and implemented, if there needed to be policy or procedure changes. And that was coming straight from their organizations they were partnering with. And in that way, that person's sole job was actually just to bring back the information and be that sort of connector.
And I assume, Kathy, that's a bilateral, like that goes both directions. It's not just feeding data back one way, It's feeding action and strategy. And yeah.
They bring them all of the latest, changes and news. And if there's a formulary change for anything, all of those kinds of policy change, they would be the person that would make sure that they were able to see it. And they actually even put the groups together. So like type groups, so they could have almost like a support for, not like an echo, but kind of like an echo where they would problem solve across the state. And it actually worked really well because they would have a rural group and they had an urban group, and it was just really good. And that was the most collaboration I've seen between payer and your provider I've seen in a while.
And William, I see your question in the chat. We're going to route that to the Be Well Texas Clinic team. And thank you for providing your email. They're going to get in touch with you about that specific inquiry.
Thank you very much. It's just a little background on that. Excuse me. I did speak to the doctors at Texas Tech Pharmacy here, or the college here, and they do, like I said, set them off with Suboxone. So if I was able to find a way to get them in there before their Suboxone runs out, would my provider be able to just take over the prescription? And then, of course, go into CMBHS with my therapist and do all the other stuff. But we could skip, because they were in the hospital. So obviously they had labs done. We can get a nursing report. We could probably get a psych eval, a medical eval, and everything. So if that little piece fits in the puzzle, maybe that would help me be able to get them in a little quicker if just taking over a prescription is all it takes. So I
Yeah.
appreciate that. Yes, please.
Absolutely. Let's get the dialogue started. So look for an email from that group. I know we're getting
Yes,
a little
ma'am.
bit short on time, but Kathy, I wanted to point to you just for a second, because as we were discussing this case ahead of time, you brought up some, I think, important questions about reimbursement considerations and sort of drawing that line between what you're measuring, how you're tracking it, but then also the steps you're taking to encourage the success of whatever that activity is. Would you mind just repeating that for the group?
No, as we've been talking, some of that was worked out a little bit, but I'm wondering if doing sort of a survey or an assessment of your all's processes and how they may either be presenting a barrier or actually facilitating what your outcomes are, as opposed to what you all are, seeing on the ground. So how can you make that connection clearer? Maybe a QI cycle where you would, help them do even a workflow assessment, like how can you streamline this? And then how can we pay for some of the things that we may be paying along the way that create more processes that become deterrents? So, even looking at it more as efficiencies. That way it's easier on their end, and then the outcomes make a straighter line between what you're reporting as your outcomes as opposed to what they are actually achieving on the ground. Does that make sense, Jennifer?
It does. And we do review our policies and our work processes pretty frequently. And we have a quality assurance department and have some really gifted project managers in that. And so as we learn more and more, we're constantly honing that, because like you said, we want to identify those inconsistencies. And if our process is causing that barrier, then that's something we need to know about and address. For sure.
Terrific. Thank you, Kathy, for repeating that. Well, in the interest of time, we're going to just move on to our closing remarks. I want to turn to B for today, just to summarize some of the key points from today's session. Thank you, B.
Thank you. Okay, so I wanted to touch very briefly and mention some of the key points that Matthew brought up related to workforce engagement, and that hiring, recruiting, promoting, and retaining steps and how important those are. And then also how he touched on, we are seeing more complex needs and pressures are on the systems, yet we are seeing a higher exit with staff. It's a loss of personnel and the pressure that is creating. And another important note that he touched on, which I think a lot of us sometimes don't realize, the important role that organizational culture plays with personnel and with employees and all of these key areas of recruiting, hiring, promoting, and retaining. So that, Matthew, thank you. And I know that these slides will be available. I know someone had asked that. Now, related to the case presentation, that was great, Jennifer. And I think one key point that we can take from what was presented from Superior Health Plan is to highlight that great approach of integrated and comprehensive model that is used, and that usually has great outcomes. The focus on social determinants of health that she touched on also, the access, affordability, and attitude, especially on opioid use disorder right now, that training and education piece, which is so crucial with the stigma that is tied to that. And there's a huge drive at the state and federal level to provide a lot of information with a focus on access, affordability, and attitude.
Terrific, Bea. Thank you so much for that wonderful summary. And I want to thank all of you again for joining this session today and making this conversation what it is. Thank you, Matt, for the terrific didactics, and Jennifer for sharing so much about the work of Superior Health Plan. We again check the chat for that survey link to the post-session evaluation for your chance to win the gift card and help us shape these sessions. We hope to see you at our next session on Thursday, August 24th. If you do want to present a case at these sessions, we'd love to hear from you. Just get in touch with the Be Well Texas team at the email address listed up in the chat or in any of your follow-up correspondence. Thank you, everyone. Have a great rest of your Thursday.